Okay, good morning, everyone. I think we might as well get this going. Good morning. I am Ben Kelly from the Australian Science Media Centre. Thanks for joining. Today we are here to discuss the upcoming flu season, specifically how our healthcare system is going to handle the recent strange circumstance of having concurrent waves of both influenza and COVID-19. Today I've asked three speakers to join us. The first one up is Professor Ian Barr. Ian is the Deputy Director of the WHO Collaborating Centre for Reference and Research on Influenza at the Doherty Institute. Next up, we will hear from Associate Professor Kirsty Short. Kirsty has been researching both influenza and COVID-19 and has been playing an important role in shaping public policy. And Kirsty is from the University of Queensland. And then last up, we have Professor Catherine Bennett. Catherine is the head of epidemiology at Deakin University. As always, we'll have time at the end of the presentations to ask questions of any of the speakers. For Zoom, you can type these questions into the Q&A box at the bottom of your screen. You can also raise your hand and we will unmute you. But please make sure to use the Q&A box and not the chat box because that won't get through to me. For anyone who's joined us by the phone, you can ask a question by raising your hand. So you can raise your hand by pressing *9 on your keypad, and we'll get it and we'll unmute you. Without any further ado, we'll start off with Professor Ian Barr. Ian, over to you.
Thanks, Ben. So thanks to SMC for the opportunity to talk to you about influenza today. And so my title is Influenza in the Times of COVID. So I'm based at the Doherty Institute, and if you want to know more about the centre, you can look up that website. So going back a year, 2021 was a very low year for influenza in Australia, probably the lowest ever. And here's a nice little snippet from the ABC News, warning us that it could be a problem when it returns, which it will this year. So looking at how influenza is tracking around the world, these are two snapshots taken from the WHO FluNet website, and this shows us the overall occurrence of influenza cases collected by the national influenza centres throughout the world. And I've split it here into the Northern Hemisphere and the Southern Hemisphere. And you can see in the top bracket here, the Northern Hemisphere follows this typical cyclical pattern where the cases are most predominant in winter and then tail off in summer. But you can see here from March, April 2020, right through 2021, that influenza cases were very low. And what we see here is different colors representing the different types of influenza which infect man. So the bluish colors are influenza A, the lighter color is H1N1, the darker blue is H3, and the brownie colors are B viruses. So you can see here in the end of 2021 that we had a rise in cases here that we hadn't seen for the last couple of years, typical of the northern winter. It had tailed off and now it's gone back up again. So more or less a dual peak happening there. So here in the Southern Hemisphere, we see the opposite usually. What's happening in our winter is the Northern Hemisphere summer, of course. Although there are sometimes cases which pop up in the Southern Hemisphere summer, but much less than in the winter. Again, similar to the Northern Hemisphere, we've seen this tailing off of cases almost down to background levels for 2020 and 2021. And interestingly, through the Northern Hemisphere winter and the Southern Hemisphere summer, we have seen quite a lot of activity of influenza in the Southern Hemisphere, and mainly been H3 viruses here shown by the blue color. So this just gives you a little bit more information drilling down onto the global pattern. This is a heat map. So the lighter the yellow, the less influenza, the higher or the darker the yellow, the more influenza, and then again breakdown by the influenza type. So you can see here some of the countries in the Southern Hemisphere which have been affected by influenza, such as Argentina, and some of the Northern Hemisphere countries which still have ongoing influenza, such as China and parts of Europe. So if we again drill down a little bit more onto some of those individual countries, this is what I was talking to you about with the increased activity over summer in the Southern Hemisphere, which is quite unusual. You can see here in South Africa, they had mainly H1 pandemic viruses. In Chile, they had mainly H3 viruses. In Brazil, they had quite a big outbreak in a number of large cities, again, mainly H3, that's now tailed off. but it's now ongoing in Argentina as well, where they're having a H3 outbreak there currently. So in the Northern Hemisphere, the return of influenza was seen in most countries. It did vary in strength. So in the USA here, we saw cases and a slight rebounding happening now. And China, very interestingly, we've had only influenza B viruses there circulating and no influenza A. UK had a bit of a quiet influenza season with mixed H3 and B. And India had an earlier outbreak at the end of 2021, which was H3 followed by B viruses. So quite a lot of activity around the globe. And the US has very good surveillance systems. So here's just a snapshot of some of their data and showing this is the current status here up until the middle of March here, showing a mixed bag of influenza with a few of the Midwest countries, states showing higher levels of activity and the rest showing moderate to low activity. And here's this dual curve here, which we saw in some of the other data here, where cases peaked and now they're troughed and now they're going back up again. But the overall impact of the season in the US has not been as high as previous years. Here's hospitalizations, and the 2021-2022 is shown here in the red. And this is a moderate season in terms of hospitalizations, and much less than some of the bigger seasons, 2017-18, 2019-20, where they had much more impact. And another measure here is the pediatric deaths. So these are recorded. So these are kids less than 18 years of age. And you can see here, 2021, there was only a single death. In 2021-2022, there's been 13 deaths so far, compared to some of the previous season where there's hundreds of children die from influenza. So how are we tracking in Australia with COVID and with influenza? I guess I don't need to tell you that COVID cases are still quite high in Australia, some 57,000 on the moving average as of a couple of days ago. So still a lot of COVID around, and that will no doubt continue through winter. What about influenza in 2022? So the bottom line here shows the cases so far, and we got off to a similar year as we did in 2021 with very low cases. Only a handful of cases detected. These are lab confirmed influenza cases. That's now gone up to 409 cases in March 2022. So that's a big rise from what we saw in 2021. The total number of cases for the whole of 2021 was only 598. So we nearly did 2021 in 1 month. So cases are certainly on the increase. It's a variable from state to state. So you can see here on the right-hand side here, the main body of infection is occurring in New South Wales and Victoria, but there are cases detected in all states. And this data was provided by the Commonwealth Department of Health. So what about Flurona? This has been a very topical thing in the news over the last few years. And how does influenza and COVID-19 cases, how do they fare? This has been termed Flurona or twindemic or syndemic. It has lots of different synonyms. So unfortunately, there's been limited studies in the human population looking at these dual infections. I think the community rates of co-infections have been relatively low during the pandemic from March to 2020 till now. Also, there's been very few studies which have looked at the Delta and Omicron variants with co-infections of influenza. And part of this reason is that influenza circulation has been low as well. So there was a meta study done by Dadji and co, which was reported last year. They did a systemic literature review, systematic, sorry, literature review, and this covered the period 2019-2020. So they did 11 studies they analyzed, and we only had 3,000 patients in that. And they had a few other things here where they had more influenza A co-infections than influenza B, which is not surprising because apart from China, influenza A was the main virus circulating at that time. And co-infections of influenza and COVID were quite low, so on average 0.8%, although there was a range seen between different countries, between 4.5% in some of the Asian countries, but even lower in the US. And they looked at some of the symptoms with these dual infections, and the most common were fever, cough, shortness of breath, were the most common clinical manifestations. So they did a sub-study where they looked at a smaller number of patients, and they had a few deaths with the co-infections, but there was no real clear sign of increased severity. So really, at the end of this study, we were left with more questions than answers. Since then, there has been a couple of other studies which have come out, and here's one that was done in China. So this is reported earlier, or late last year, sorry. And they looked at, again, a reasonably small number of patients. So 285 COVID patients, and 36 of those were co-infected with the H1 pandemic virus. And this was only adults and hospitalized adults as that over the age of 18 years of age. So they had a co-infection rate in these which was higher, and the co-infection was mostly in the older groups, and they had poorer clinical outcomes. So you can see some of the adjusted odds ratios there in the table on the right, and they showed higher rates of acute kidney injury, acute heart failure, secondary bacterial infection, ICUs compared to the COVID-19 alone infected studies. But this still doesn't tell us much about H3 or B co-infections, and it's a relatively old study done in 2020. So here is one of the most recent studies we've seen. This is a study from UK hospitalized patients, a large number, 6,965 patients studied between 2020 and 2021. And they looked at co-infections with influenza, adenovirus, and RSV. So you can see the co-infection rates are still relatively low, 3.2, 1.9, and 3.1% respectively. But what they found, and the table shows you here, that when you had co-infections, there was 4 times the odds of being put onto mechanical ventilation in those hospitalized patients, and you had 2 times the odds of dying in hospital. So it appears that hospitalized patients certainly have poorer outcomes with dual infections of influenza. And interestingly, in this study, they couldn't demonstrate any increased severity with adenovirus or RSV co-infections. In contrast to this study, there was a recent study from India, and this was quite a large study, 13,467 cases. This was conducted from both hospitalized and community patients. They didn't give the breakdown of how much in each group. It was conducted between July 21 and January 22, so one of the most recent studies, and they looked for just SARS-CoV-2 infections and influenza, and they found only 5 cases with co-infection. So that's 1 in 2,500 people. So very, very low numbers. 3 out of 5 of those cases were admitted to hospital, and the other 2 recovered at home. And the 3 hospitalized cases were elderly, but none required mechanical ventilation, no ICU, and no deaths. So quite a contrast between the Indian outcomes and the UK study. So in summary, 2021 was an historically low influenza season in Australia, probably the lowest ever. There's been resurgence of many other respiratory viruses, unlike influenza, such as RSV, adenovirus, human metapneumovirus, to name a few, in 2020 or 2021 or both. Influenza activity in 2021, 2022 in the Northern Hemisphere has been variable, but certainly increased from 2021. Influenza activity in Australia in 2022 is increasing, and we know that COVID-19 is circulating quite widely. In terms of the Flurona thing, so co-infections in the community are generally low, less than 1%. However, the co-infections may be higher in some hospitalized patients. I gave you the UK study where it was 3.2%. Hospitalized patients with co-infections may have further complications, as outlined in the Chinese study, and may have higher rates of mechanical ventilation, ICU, and deaths, as indicated in the UK study. The Indian study, in contrast, reported very low rates of co-infections. We do need more studies, though, that cover all influenza types, lineages, recent variants, especially the Delta and Omicron and the variants of Omicron, to see whether this is still the case. And we need to look at ethnicity, all the age groups, comorbidities, and other factors such as nutritional status. So in light of the lack of data, or the slightly negative data, if you believe the UK data, that it's quite obvious that vaccination against both COVID-19 and influenza should be recommended and taken up by the public. Other non-pharmaceutical interventions may mitigate influenza: masks, social distancing, hand washing, use of air purifiers, staying at home when sick with influenza-like illness, etc. But nothing will stop influenza getting into Australia and circulating. The only question is what level it will circulate in 2022. Thanks, Ben. And just remember, Arnie told us all about this. He's going to be back, and so will influenza.
Thanks, Ian. All right. Next up, we have Associate Professor Kirsty Short. Kirsty, you can take the ball.
All right. Thank you very much. Let me just share my screen. I'm hoping everyone can see that. If not, please tell me. Otherwise, I'll just keep going on. So I'd just like to start by echoing some of the comments that Ian made. And essentially it comes down to this, that co-infections with SARS-CoV-2 and influenza are certainly possible. They have been relatively rare to date. And as Ian said, that's clearly indicative of the fact that flu hasn't really been circulating like it normally would. So this is why we've got to be wary of this upcoming winter season. And also just to highlight the study that Ian mentioned, this study from the Lancet here showing that influenza and SARS-CoV-2 co-infection was associated with increased risk of invasive mechanical ventilation and in-hospital mortality. But also, as Ian said, this is not a universal finding, and there has been differences between some of the clinical studies. So what I wanted to do in my little slot here is to walk you through what we know about influenza and SARS-CoV-2 co-infections in experimental models, because in experimental models, we have the capacity to control for a lot more variables. So it does make it easier to distill patterns. So when we talk about experimental models of co-infections, these have largely been in small animal models, specifically in mice, but also in hamsters, because hamsters are a very good model for SARS-CoV-2 and influenza. And there's been a fair number of studies that have been done in these small animal models. And overwhelmingly, the consensus seems to be the small animals experience more severe disease when co-infected with SARS-CoV-2 and influenza compared to infected with one pathogen alone. So you can see that on the left here with the mouse data. This is looking at weight loss, and weight loss is sort of a marker of disease severity. And you can see the co-infected animals shown in purple lose significantly more body weight than the animals infected with just SARS-CoV-2 alone or with just influenza alone. And then on the right, you can see the same thing, albeit with a bit more variability in a hamster model. Again, the co-infected animals, and here they're shown in red, lose significantly more body weight than the animals that were infected with SARS-CoV-2, shown in blue, or influenza alone, shown in green. So this is providing us with some really nice experimental evidence that probably co-infection with these pathogens is suboptimal. The question then becomes, okay, so disease severity is increased during a co-infection. Why is this happening? And one possible explanation for this is, well, maybe when you have both viruses in the lung, they both replicate, they're sort of propelled to replicate further by the other virus. And that's what's causing disease. But the evidence for this hypothesis doesn't really seem to be there. So what you can see in a mouse model, and this is shown on the left, is if you look at the amount of infectious virus in the lungs, and here we're looking at the amount of infectious influenza, and we compare mice infected with influenza alone compared to mice co-infected with influenza, you can see that, okay, maybe there's some weight to that hypothesis because we get more flu replication in the lung of co-infected animals. But when we look at the replication of SARS-CoV-2, so our other virus that's in the lung, actually it looks like it's decreased in co-infected animals. So it's not as clear-cut as when you have a co-infection, both viruses replicate like crazy. Moreover, when you look in the hamster model, actually you don't see any difference in the replication of either virus in co-infected animals compared to animals infected with just one virus alone. There's been some evidence in the literature to suggest that maybe co-infection causes both viral infections to persist a bit longer, but this certainly isn't clear-cut. So I would say the conclusion from this is that in the lab, we can see that co-infection causes worse disease, but this probably isn't really a matter of just increased viral replication. One of the things that is really consistent with the experimental studies is that when you have co-infection in the lung, you actually have increased inflammation. So these are data from a mouse model, but you can see the same thing in the hamster model. And what you can see is that in the co-infected mice, shown here in blue, you actually have a significantly higher number of cells in the lung, and that's indicative of inflammation, because the more inflammation you have, the more cells get recruited to the site. But also, when you look at the blood, you actually have a significant drop in immune cells. And that also makes sense, because if you look to this figure on the right here, what happens during inflammation is that if you have inflammation in the lung, you get all these cells being recruited to the lung from the blood. So your immune cell population in the blood goes down, the number of cells in your lung goes up. And unfortunately, these immune cells can actually cause a lot of tissue damage to the lung. And what that will ultimately mean is that the lung becomes a bit leaky. It can fill with fluid. And you can imagine, you know, from a patient experience, if you're trying to breathe and you have fluid in your lung, that's very difficult. What's also very interesting from these studies is that it's also suggestive that the antibody response to both influenza and SARS-CoV-2 during a co-infection is actually lower. So this raises questions about whether this will have impacts on long-term immunity. Maybe you have better long-term immunity if you have infection with just one virus versus infection with both viruses. But certainly from the experimental literature, the overwhelming consensus is that co-infection is typically worse because it results in increased inflammation and therefore increased tissue damage. The question then becomes, well, what can we do to prevent this? And certainly there is some information we can glean from the experimental literature to inform this. So this was a very nice study looking at what effect influenza vaccination had on these co-infections. And what they saw really clearly is that this increase in disease severity that you get during a co-infection can actually be blocked by influenza vaccination. And they did either influenza vaccination on the left, or actually what they did on the right is they transferred sera to mice. And they could show that just that transfer of sera was protective against this disease severity in co-infections. So that, combined with some other experiments, tell us that it's actually the antibody response to the flu vaccine that can play a really protective role in these co-infections. So I think in light of the experimental evidence coupled with some of the surveillance and clinical evidence that Ian has talked to you about, the take-home message is really, this is a key season to get your influenza vaccine. If you never got influenza vaccinated before, now is the time, because at the moment, that seems to be a really powerful way to stop the disease severity if you happen to be co-infected with SARS-CoV-2 and influenza virus. Thank you very much.
Excellent. Thank you for that, Kirsty. And we'll move on to our final speaker. We're going on to Professor Catherine Bennett. Catherine, please.
Thanks, Ben. I didn't bring slides because I knew my colleagues would tell the big picture story, particularly Ian's lovely presentation of actually what's been happening over the last couple of years, both in the Northern and Southern hemispheres. And that is really important because we watch the Northern Hemisphere, we expect our season to be influenced by the Northern Hemisphere flu season. And we learn everything from that, including, you know, how to construct the vaccines and so on. But what is interesting to me is that we've got so much going on here and still that we don't understand. And a lot of the countries that we've talked about today haven't gone through the same COVID zero and therefore flu zero or close to history that we have had. So we are in unknown territory, coming off the back of particularly 2021, where we saw that combined effect of 2 years, particularly of closed international borders. I remember a year ago hearing some work done out of Glasgow where they were looking at a cellular level. They created a cell model, not even an animal model, but a cell model looking at how the virus could invade cells when you actually had viruses competing. And they were looking at the rhinovirus, the common cold virus, and found that actually could boot out Omicron, the SARS-CoV-2 virus, not Omicron, sorry. But at the same time, it would have the advantage at that level. So it gave me hope that we might actually have a healthy competition from our point of view, where cold might supersede SARS. But that's not necessarily what we're going to see. And when you look, we move from the cellular level to the human level, there are so many other things going on. I think the other thing to think about when people are faced with multiple infections from an epidemiological point of view is how they respond to that in terms of reading symptoms. So we always worried going into the winter seasons over the last couple of years that those signals that someone might have a COVID infection, even though it's not absolutely reliable because some people have either obscure, very mild or no symptoms, but at the same time we rely on that symptom presence to really signal a probable case and therefore take action. And you lose that when you start to really cloud that symptom picture. So that's something else that we need to worry about, just in terms of what signals people have that means that they should even just seek testing. The other thing I think is understanding, again, the pattern of individual response. So if you're unwell with a cold, you take yourself out of circulation. That probably does reduce your risk of flu. So there'll be other things happening in that human behaviour response to multiple infections circulating, particularly if people can't get tested or are waiting for testing or whatever to understand what symptoms they might have. But the other competition here, of course, is with the vaccine itself, and the fact that people are already expressing vaccine fatigue. And it was one of the conversations early on, again, a year ago, when Novavax were pulling out all their guns and actually testing a combined flu and COVID vaccine, and people thought that could be a good idea. But some others have said, well, we have to be cautious about that because it might actually undermine the flu vaccine campaign if people are still suspicious about a COVID vaccine, particularly in places like the US. So they were worried about hitching onto each other because it might not have, as a combined efficiency, it might bring other concerns in that might not see a good vaccine uptake. And that's particularly the case in the US, where they haven't had anywhere near the kind of vaccine uptake that we have in Australia. Just coming back to comments Ian made, the big difference for us now is the opening up of the international border. And you could see that that was actually something that accumulated over time, even though states in most cases, in fact, in all cases, had less time in lockdown with very severe precautions through the first part of 2021 going into our flu season. We still didn't see the cases. We still had that longer term protection from really reduced travel and movement. And our travellers were coming in through hotel quarantine for most of that time. And even though they weren't targeted and tested for flu, they were quarantined for 2 weeks. And that gave us a window to clear the virus and to reduce the movement of the virus into the community. I think we're also seeing some impacts of other precautions in place in this twin peak that we've seen across the Northern Hemisphere. And I suspect that's probably coinciding with Omicron and the short-term sort of closing of border, but the disruption that happened with that, including in some settings, lockdowns, or at least a ramping up of requirements or advice on precautions. So I agree with Ian. We're going to have the virus here. We can't stop that with the borders open, but I still think those other precautions can help and will help. But absolutely agree with both Kirsty and Ian that this is about vaccination. And if we've lost that immunity, not just the vaccine that people mostly will have had in previous years, which may have dropped off in the last couple of years, but also just that incidental rubbing shoulders with the virus. If you don't get a full infection, you may not get symptoms, but you might have actually boosted your immunity and you haven't had that opportunity over the last couple of years. Then that means actually working to boost it, particularly with the signs that we have an early flu season starting with the case numbers we've already seen in March. Then I think this is something that we really want to get that message out so people understand the importance of protecting against both. So I might stop there. Thanks
for that, Catherine. All right. As always, there is now a time for anyone to ask questions of any of our speakers. Just to remind you, you can use the Q&A box, which you'll find at the bottom of this little window you're looking at. Please don't use the chat box, because again, that will go off into the ether and I'll never see it. If you're on the phone, we have one person on the phone right now, you can raise your hand and we'll unmute you by pressing *9. But yes, to get everyone kicked off, Ian, why do you think we had such a big hike in flu cases this year compared to last year? Just a quick and easy on there?
Yeah, look, I think Catherine and I think Kirsty and I would all be agreement that the major factor in all of this is the international borders. And what we saw last year, the only cases which we detected coming into Australia came through the quarantine stations, mainly in Howard Springs. So without that protection, I think cases will come in. I think I didn't show you any data, but there is currently outbreaks in Fiji, New Caledonia, and there's been a rumbling situation happening in Timor-Leste. So places very close to Australia with current cases of influenza. So, some of those travelers will no doubt come into Australia as well. So it's a numbers game. And when there's a sufficient number of cases coming into Australia, that will kick off the epidemic for 2022. What we don't know is how big that epidemic will be. And that's very difficult to be precise about. But we have to prepare for, I think, probably a moderate season. And so hence the vaccination call.
Have we started rolling out our vaccines for influenza now?
Yes, according to the AIR database, there's been 199,000 people vaccinated so far as of the 3rd of April.
Sounds like I need to go get my vaccine early.
Well, we need a few more done than 199,000, that's for sure.
Sure.
Last year, numbers were down. We only had 35% of the population vaccinated.
Oh, wow. All right, we have our first question in from Bianca Roberts, who's from news.com.au. Bianca asked, a second booster campaign has begun for older Australians, especially those in residential aged care. Is it safe for older Australians to be seeking a flu vax as well right now?
I can just answer from the advice that's been passed on to me by our vaccine experts, but yes, they're suggesting that you can have the two together. The only reason they actually separated the vaccines previously was because they were monitoring very closely what reactions there might be to each vaccine. But now, absolutely, it just makes it much more efficient. People can have both doses at the same visit.
And I guess just to add to that, stressing the importance of vaccination for both COVID and influenza in the elderly population, because for both viruses, age is a risk factor. So it's something that people really need to take seriously.
Yeah, the one shining light from 2021 was that the age didn't drop their vaccinations. Everybody else seemed to, but the age over 65 didn't. So good on them, and let's hope they can keep that going this year or even improve on it this year.
And just to say, if you're not due for that booster, the second booster, if you're in that over 65 or over 50, if you're Aboriginal Torres Strait Islander, that you can have your flu now, though. Don't wait for the flu. You can have your flu dose, and then as soon as you're eligible for the COVID, have that.
Excellent. Thanks, everyone. Kirsty, I wanted to pick up a point that you mentioned. You said that co-infection might lead to lower immunity than being affected with just one. Would this then alter the, the super immunity window that every state has currently? Like I know in South Australia, you get 12 weeks where you're super immune.
Yeah, I mean, I would hesitate to ever use the term super immune because what we know about immunity to infection is that it's highly variable from person to person. So it depends on lots of things, not just the exposure to the virus that you had, but also your underlying factors, age, comorbidities, in particular obesity has a role. So I would just say it as a word of caution. We don't have great evidence for this. This is in an experimental model. It needs to be validated. But I would say that it's something that we need to look into as to whether the immune response that you develop during a co-infection, whether or not that's the same or inferior to the immune response you develop as a result of a single infection. And we don't have the data yet, but I just think it's one more piece of the immunology puzzle that we need to figure out going forward. And this is the ever-changing nature of the pandemic, right? That we always have to adapt, and we have to adapt our knowledge accordingly.
Excellent, thank you. All right, moving on from that, Catherine, you said that we might not want to combine our vaccines because everyone's starting to get quite exhausted with having to go back and get all their boosters. Do we think that if we had, say, policy that kind of just put us in the place where, you know, vaccines became mandated and things like that, would we want to bundle the two instead?
I think mandating was part of the problem, which brought up some resistance to the vaccines. And that mainly came from overseas. As I said, we've had a really good uptake here in Australia, but there was a concern that if, you know, you couldn't choose to have flu or COVID or both, but you're in fact required to have both, that it might undermine, you know, the uptake overall. So that was just one of the questions that relates to some of the concerns that are out there. We still have people that do not want an mRNA vaccine, you know, for COVID. They're the people that waited for Novavax or had AstraZeneca as their booster on top of their primary course. So there's a lot of questions around that. And so I do think that took the foot off the accelerator a little bit in terms of coming up with a combined vaccine just at this stage. But I don't think that's going to stay that way. I think our vaccines might look very different down the track. And I think the fact that you can have them both at the same time is you know, helps with that efficiency for the people who just want them both, because they know that having both, particularly those people in the risk categories, is going to be really important for them this winter.
Tailing on to that, do we think that we're going to start getting COVID vaccines that are tailored for specific variants coming down the line like we do for influenza?
So, I mean, I can answer from the immunology perspective. It's a really interesting question, and it's certainly something that people are investigating. So the current experimental evidence, surprisingly, I would say, or at least it's not what I expected, was that if you did a boost with, say, an Omicron specific vaccine, that was not actually markedly different from if you boosted with the ancestral virus. Now, there could be lots of explanations for that. One suggestion that's coming through in the literature is maybe we're looking too early, and maybe if you boosted with a variant-specific vaccine, you would actually get longer immunity. So that's something that we need to work out. But certainly the evidence to date is surprisingly suggesting that even though we're using the ancestral virus, that it's actually still really good.
Catherine, oh, Ian, sorry.
No, I was going to say, in fact, if you go back even earlier to some of the earlier SARS coronaviruses, they seem to give very broad protection as well. So, you know, I think there will be a lot of work done in this area, and I think inevitably we will have an updated vaccine, whether that's for Omicron or something further down the track. But I think that's probably inevitable. And
I was just going to add that we now have, you know, very few people who are immunologically naive, who haven't either had vaccine or infection. And so it's actually the combination now that we're living with the virus in the community, even in Australia, that actually also impacts your immunity. But I do think it's fascinating, the different protection you have with the booster over the primary course when you look at Omicron, which is that bit more different again, and really did undermine protection from infection, even though it's still protected from serious illness. And the latest data I saw out of the UK, they've always talked about symptomatic infection and how the booster could reduce that by more than 50% over those first few months post-vaccine. But in fact, they've now upgraded that to say any infection. So that's pretty amazing that you actually can, with a vaccine derived from those first circulating variants, still have that level of protection. Of course, this is real world data, and we're talking about populations where they've had high levels of every variant actually in the UK. So all those things might play out slightly differently because we've had different immune challenge histories, but at the same time, it does give us hope that we're progressively just broadening and deepening our immune protection in a way that means we may not have to just chase every variant with a brand new version of the vaccine to try and get on top of it again, that we've got this sort of accumulated protection now, which seems to take the edge off. And I think that was the whole conversation about Omicron, saying it was mild, when I think the best evidence suggests it's probably no different to those first circulating variants. It's we that have changed, and that really does help take that pressure off hospitals and take away the risk, not for everyone, but for most, of that more severe disease that we saw so much of in the first wave.
Yeah. All right. just for a reminder, everyone, we're up to our last question from everyone. So if anyone has anything else, please pop it into the Q&A box now. This last question is from Thea O'Connor. Sorry, Thea, I don't have your organization here. Is there any evidence that the flu vaccine reduces the severity not only of co-infections, but of COVID alone?
I wish. It would be great if the flu vaccine could protect you against just COVID. But unfortunately, the way in which these vaccines are designed is that the flu vaccine is specific for flu, and that's the sort of immunity that it elicits. And the SARS-CoV-2 or the COVID-19 vaccine is specific for the SARS-CoV-2 virus. So no, a flu, if you're not vaccinated against COVID, getting vaccinated against flu is great, but it's not going to protect you from COVID.
Yeah, I think some people think that, the non-specific immunity that you generate, and you probably do generate some with any vaccine, will be beneficial, but I think that will be very minimal in this case. And where people have tried to razz up the immune system by using live vaccinations, such as BCG, that hasn't given any impact on protection. So I think the influenza vaccine is quite a mild vaccine in terms of the immune response that it generates. So I think it would be very unlikely to do anything against COVID.
So get both vaccines is the answer here, it seems, which is a pretty good kind of wrap up. So I guess I'm going to say thanks to everyone for joining us. For a copy of today's briefing or any kind of follow-up contact information for any of our speakers, you can get through to us at the SMC, the usual methods, which is head over to our website and drop us a link on info@smc.org.au, or you can give us a call on 08 7120 8666. So finally, just a big thank you to everyone for joining in and listening in. Thank you to all the speakers, of course, and we'll catch you next time.
Cheers.